Okay, so the last session is a panel session, and we're going to have a discussion about, our sub-theme for this session is minors, so I'd like to invite Professor Yoke, Dr. Kumu Rajasekaran, and also Dr. Jonathan Choo to join us on the panel, please. So we've obviously been introduced to Yoke and Kumu, but I'll introduce Jonathan as well. So Dr. Jonathan Choo is a pediatric and fetal cardiologist at KK Hospital, and so he's trained in both pediatrics and cardiology with various research interests. And in terms of clinical ethics, he's also involved on clinical ethics committees at the hospital and also at national levels. So if you have the energy, please join me in welcoming the panel to the stage. Okie dokie. So we have a couple of cases to stimulate conversation on this topic. So without further ado, let's look at the first case. So this one is a case involving a healthy pregnant woman who was initially informed that her fetus had bilateral multicystic kidneys and advised of the likely poor prognosis. So she chose to continue the pregnancy. However, soon afterwards, she was told that the fetus condition had worsened, and so it was unlikely to survive if born. She was asked whether she would like to terminate the pregnancy, but by this point, she was 28 weeks pregnant. So termination can be carried out by either inducing delivery, which then could result in a possible live birth, or by intracardiac injection of potassium chloride. And this means basically injecting potassium into the heart of the fetus to stop it, and this would result in a stillbirth delivery. So now, just for your information in the context of this case, the law in Singapore is stated in Section 4.1 of the Termination of Pregnancy Act. And that says that terminations are not allowed where the pregnancy exceeds 24 weeks of duration unless the treatment is immediately necessary to save the life or to prevent grave permanent injury to the physical or mental health of the pregnant woman. Okay? So 24 weeks, no abortions unless this criteria is satisfied. And the question that we would like to ask you, and I'll read it first before I go on to the question on the screen, is should the termination of pregnancy be carried out? And so we've given you three options, the standard yes, no, or unsure. We've got unsure in this panel. So should the termination be carried out, yes, no, or unsure? I wonder if I'm going to be surprised or not. Okay, maybe not surprised. More on the unsures, though, than the standard, right? We've been seeing 13 to 15% unsures when we have unsure as an option. Well, this is interesting. Okay, anybody in the audience want to get us started?
Hi, I'm Binhui from KK. I'm a neonatologist. I answered because I have friends staring at me. It's like, you better answer. Okay, so in this case, I think if you talk about the rights of the fetus, or what is in the best interest of the fetus, in this case, I assume it's bilateral cystic dysplastic kidneys, and there is, once the baby is born, this baby will not live. So that's one. Okay, if you talk about futility of care, in a way. So, in this case, I think the mom has requested for termination, although she is already past the so-called legal limits of abortion. But also I think we have to think about, for the mom's side, is the act of termination safe for her at 28 weeks? I think that's the part where I'm not sure whether I'm not an obstetrician. So is it safe to carry out this act of termination on the mom? Is this going to cause any harm for her? And probably it's more of also if you have to think about what is she thinking about? If what would this cause her in terms of if you actually prolong the pregnancy, what is the impact of her carrying this pregnancy to term, knowing that once the baby is born, the baby will not live? Is this likely to actually cause her more mental stress? Is it likely to cause her more, more harm in that sense? Especially if she has already decided that, yes, she's ready to let go. On the other hand, we do have parents who know fully well that once the baby is born, that the baby will not live. But they do not want to terminate the life of the baby. And they will say, once the baby is born, I will let the baby go. And they just want to spend that little amount of minutes, or sometimes they do live on for maybe an hour or so. And this is what they will live with. Okay, so that's why I think usually in these cases, we actually refer to our palliative colleagues, okay, who are really very good at walking through the journey with them. It's also deciding what happens when a baby is born. What do you want? Yeah, making memories. What is the limit to the resuscitation or so-called options that you have? Yeah.
Well, thank you. That's great. Anyone would like to build, from the audience first, anyone would like to build on that point or offer a different point of view?
So I think this case was helped by the fact that the mother asked for the termination.
It's a what, sorry?
It was helped by the fact that mom, the pregnant lady, asked for the termination. It reflects the values that she has. I guess where the medical team can come in is to kind of explain to her the different options, like the timing, for instance. Whether it would be, like if she feels ready for it now, what are the risks, and then compared to, say, if she carries it to term, would she be less, say, mentally prepared, her body would suffer less harm from carrying the baby too. So I myself voted for, yes, it should be carried out, but I think that the variability would be the timing and the preparedness of the mother.
Thank you. Did anybody vote no? Well, I do know people voted for 42%. Could we have somebody who said, one of the 42% who said no? Why no?
Okay, I said no because first, the thing is I'm not clear what are the physical and mental permanent injury that the patient will be getting by continuing it. So I think shouldn't be, and the other points is similar as the previous speaker has said, that the bilateral multicystic kidneys is not really like debilitating. Maybe it's problematic to be faced with, but I don't think it's a disease that is can't be handled, maybe. So have to explore more with the parents. Will the mother be able to handle this child if the child is born alive? So to me, I think not yet. The answer is no.
Sorry, the answer is no, the mother's not, well, hopefully it's both the parents.
I don't think we should terminate the pregnancy.
Oh, for now, because we need more information is what you're saying. Okay.
And then I'm not clear about the physical and mental health to allow the termination of the pregnancy.
Okay, thank you. All right, well, maybe this is a good point to kind of bring in the panel then. So some questions or uncertainties about a number of things, right? One in relation to the 24-week rule and the reasons to permit termination beyond what would probably commonly be called the point of viability, right? 24 weeks. And the other point was in relation to the seriousness of the condition that the fetus seems to have. Okay, so who'd like to kick us off on this?
So from a knowledge perspective, this multicystic dysplastic kidney is fatal. It's not compatible with life. So in a sense, if it is not compatible with life, then you take that part of not knowing away from it. That comes from the medical indication of whether it's required or not. Obviously, you have to have good indication to go against the law, because you also don't want to be committing a crime, in a sense, right? So that's the balance you have to do. And then the person who is carrying the fetus is the one that has autonomy over her body, right? And the choices that she makes. And I agree, you cannot assess at that time what it could be her mental state if the termination has taken place. You can probably then have a conversation with her about these are the options of termination and this is how it's going to happen, and the options are there, and then you can see from her response which one there is appropriate. So I keep things very simple. So you assess the situations, you look at the principles of what is there, right? What are the balancing principles that you're looking at, right? You compare consequences and alternatives. So, you go through it in a way that balance. And me and Jonathan have always talked about proportionality. What is that balance that you want to achieve, and what is that? As safe as possible. Bring it down to that bottom line that I always talk about. What is the safety issue? What is the safest option? Right? Knowing full well that this baby will not survive at all.
Maybe a quick clarification. When we say the fetus is not going to survive, are we talking, when is the likelihood of death?
I think, and Bin, I don't know if you can correct me if I'm wrong, there is a possibility that it is already stillborn when you deliver.
Okay, so they're stillborn,
right?
and
you can, or there's days, so you have to be able to give that sort of a gauge and an option.
Okay, so we're talking about very soon afterwards. We're not talking like 10 years down the line or something. No, okay. I see. The lungs are not developed.
So I like it when it's like that. Okay, when a case is written such that you get this kind of results, it really shows that this is a true ethical dilemma. Because people are split, right? And everybody has their own reasons, and this is a real, true ethical dilemma. So when you're faced with this kind of ethical dilemma, the first thing you should do is to make sure that whatever recommendations you make does not contravene the law. And the law is different in different countries, right? So in Singapore, like what Sumi has said, a woman are allowed to abort their fetus before 24 weeks, irregardless of what the reason is. You don't, in fact, actually, they don't even need to give the reason. You don't need a reason. Yeah. They don't even need to give the reason, as long as the woman wants to abort, that's it. But after 24 weeks, that's when the problem starts. Because if you miss the golden period of 24 weeks, you cannot abort unless continuing the pregnancy will cause medical harm to the mother or mental harm, okay? So I think the question was, what will happen to the mother if the pregnancy continues? Medically, I think nothing will happen, I think. Physically, probably nothing will happen. But mentally, we don't know, right? There's going to be distress, you're carrying a baby that might die, okay? Then that's the other thing. Science is advancing all the time. Something that we think will not result in a live birth may even have an option of being treated in utero. Okay, so when I was a training medical student and all that, this condition called Barrett's fetalis, which is where you have a certain abnormality in the gene, you have thalassemia, and the baby does not make enough blood. Okay, eventually the baby is born stillbirth because it dies of heart failure because of anemia. But nowadays, you can actually transfuse blood to the baby in utero. Okay, so the baby can actually be born alive, and then you go ahead and treat the child. So while it is true in the sense that children with dysplastic kidneys will likely not survive, I'm also cognizant of this case that Dominic shared with us last time, where he visited a US ICU and he saw this baby with Potter's syndrome, which is also kind of similar. There's no kidney function, basically. The baby was born with no kidney function. The moment the baby was born, US being US, right, they put the baby on dialysis. These neonates, right, put the baby on dialysis. And then he was appalled. He's an ethicist, right? He said, what in the world are they doing? I mean, US, I know they got a lot of money, but this baby has got no kidneys, okay? Usually, people will just allow the baby to die. And he thought, they're wasting money, and all that kind of, so he went back. And then later on, he wanted to find out what happened to the child. He wrote to his counterpart there, and the counterpart told him, oh, the child had a kidney transplant from the father. He's now alive. Okay, so you never know, this kind of thing. You really don't know. So just something to keep at the back of the mind. And something that I think Bin was talking about, fetal rights. In Singapore, at least as far as I know, the fetus doesn't really have any rights. Okay, as long as the fetus is not born into a baby, the fetus doesn't have any rights. So we really look at this case on the mother's perspective. Yes, the mother has a choice over her body, but you also cannot contravene the law. So if you assess that the mother may not be so mentally distressed by the fact that she's carrying the baby to term, then by law, you're not allowed to abort the child. Okay, but if you think that this, by her carrying on the pregnancy, she's going to be suicidal or cause a lot of mental issues, then you can justify termination on that sense.
Maybe I'll just add on, it's always hardest to go last. But the thing is, I think it's important to have more information. Very often, when questions come to the ethics board, the ethics team, we don't have all the subspecialties, within the team. I mean, we have lay people, but within the team itself, the medical people, there are certain specific subspecialties, and we don't know everything. So very often we have to go back to the physician again, and the primary physician, ask, what is the prognosis in this situation? What alternatives are there? And what other therapies are available? And all that information is important. Back to what the lady said just now, what other information is there? And I think information from the social work psychologist is also important with respect to the mother. Is she at risk of mental distress? And if so, what is the degree? And then we can answer the legal question thereafter from that perspective. The next thing is, really, is there maternal danger or not? And if, let's say, we have a situation where having a fetus in utero presents the mother with possible danger, what is the degree? How often do we have to monitor this pregnancy? Is that feasible or not? And then it comes to the situation of, risk of permanent injury to the mother. So if we put all that into context, then we can then formulate an answer, with the best information that we have. Because I believe that good medical practice comes from good evidence and good information. And of course, we use the ethical principles to build on all that.
Thank you. Any more comments? Well, there could be additional comments from the audience now that you've heard some of the reflections when we're thinking about, the condition of the woman, bearing in mind that she might have to, given the circumstance, right, the medical diagnosis for the fetus is that it's very unlikely to be born to term, and if born term, likely to be stillborn, but if not stillborn, will be born and likely die very soon after the birth. I would imagine that some women might approach or think about this quite differently, right? So some may think or become very distressed at the thought of carrying a fetus for another, 12 weeks or so, only, and of course, increasingly become attached to the fetus, only then to have to give it, to watch either a stillborn or watch the child be born but then die very soon after. But maybe perhaps somebody else might think that by carrying the fetus all the way, as far as they can, and then for the fetus to be born into a child, they might find that this offers them closure. So I can see that, I would like to think that there may be different ways of looking at this, but in terms of whether it's, when we think about the law and we think about different people's approaches or, the woman's different way of thinking about this, in many ways the law has been drafted with a certain degree of flexibility, right, in terms of the clinical judgment. But I don't know, maybe some people here disagree.
Hi, this is a very interesting case because I'm purely looking from a legal perspective that this lady has passed the 24 weeks, okay? So the option is, I would just look at it from a purely, is this pregnancy going to cause her physical harm, That's an assessment required from a clinician's perspective, or is this patient going to be mentally affected as well? So there are two factors you need to consider. So she's passed the legal threshold. So if these two can be fulfilled, there was not enough information in the case study. So it all depends on the clinical assessment. Now, there are two factors involved: inducing delivery and taking the term to full term and then deliver is the same thing. You're not actually killing the baby, but you're inducing the delivery at some point. It could, she could go into labor even any time after her 29 weeks. But this is forcefully induced. So it's, the end, if the physical condition is going to be of the baby is that the baby's not going to survive, it doesn't matter whether you induce this is my point of view, whether you induce it or whether you take it to full termination, the baby is likely not to survive, okay? The thing people would have an issue is injecting with the potassium in the heart.
Oh, we haven't quite got to that question yet.
that people may have an issue, and that's an ethical issue, and depends on people's values. But from a legal perspective, determine, is this woman, what is her state? How much does she want the pregnancy terminated before full term? That's one point. Secondly, is that going to affect her if she carries it to full term? If not, then, she has to, it's a few more weeks, as you say, 29 to 36 weeks, let her carry on. So this all depends, again, the clinician's assessment of her mental state and her physical harm. If it's not going to physically harm her, then it's just the mental state. You need to look at it. So that's how I look at it. I think the option of injecting something to the fetus in the heart and then getting it stillborn, I think it would be objectionable to a lot of people. Depends on the values. So, yeah.
I'll save the question of whether it's legal in a minute. There's a question, or rather a comment from somebody at the back.
Hi, sorry, may I ask a question? I wonder what is the evidential threshold required to show that the injury is permanent and severe? And okay, I'm asking this in the context of, let's say if I have a patient with stroke. It was a real case. She was about 5 months pregnant. So thankfully she had mental capacity. I know the law just requires the woman to consent, right? As in the injury has to be done to the woman and it has to be shown that, and I suppose the consent of the woman is sufficient for the termination. So what if we have a scenario where the husband objects and then say that, oh, actually the wife is just pretending that it's going to cause her a lot of injury, but actually she just doesn't want to keep the child. I wonder if that has ever happened. I don't know whether there's any case law, but yeah, just throwing out the question. Thank you.
I know my temptation is to say she should be divorcing him, but okay.
I don't think there's any case law. It's in a situation like that. But you're right. I mean, if you think about it from the perspective of what is the threshold for mental distress, I think that's something that we need to establish. Very often, you need a psychiatrist to come in and to establish that the degree of distress that the mother is facing from the mental perspective. So that's with respect to that part of the question. I'll probably leave the husband question aside for a good reason.
I thought we talked a lot about it, right? Nobody can make a decision for you if you're competent.
Yes.
There's no relational autonomy for the husband.
It's the end of the story.
It's like full stop.
But having said that, actually, the interesting thing is there were some cases of spousal consent in our regional countries, which we debated a lot when we discussed this case before. But if you look at the case, it's actually not really about the husband consenting for the wife. It's about something else. So basically, nobody has the right to make a decision for a competent person, even if he is the husband or the wife or the parents or whatever. It's really, if you're competent, I'm saying if you're competent. But if you're not competent, then who should make the decision? Is it the husband? we discussed this, right? I mean, we hope that it's going to be a collaborative thing. It really also boils down to the healthcare professionals' medical opinion, and then with help from the husband's views lah, the parents' views lah, and society lah, and all that sort of thing. So just because you're married doesn't give you a right over your wife's body lah, huh?
Okay, I'm just one point of that. It is something about making a decision for someone else, right, without that mental capacity. So just have to think about it logically. Just give you an example. So if you have a case of a minor who's had a sexual assault, let's say in Singapore's context, right, you have a form for forensic examination. The parents sign the form. But if that young person says, no, I do not want to be examined, I know no doctor who will force that examination. None, even though there's consent, there's parental. So again, that you have to think about it. That being said, that doesn't mean you don't engage the husband in the conversation. That doesn't mean you don't have a conversation about that, because that is what we're talking about, right? It's communication, and it's not about one person's decision. But in this particular case, I think then the best interest one will probably, what is the best interest for this individual that has no capacity? And the physician then will probably take the lead from a clinical indication point of view about what's going to happen to the woman and the fetus specifically. This woman had no difficult stroke, right? Or had capacity. But let's say if she had a stroke and no capacity. That's...
Maybe I'll just bring this to one level next. So if you think about it then, why should a woman have absolute rights over a fetus? And is it absolutely correct that the fetus has no rights? Just wanted to throw this question out. How would you consider a fetus? I know that this is a very challenging question because there's a wide variation in thinking based on values, based on perspectives. But I mean, it's something to think about from the ethical perspective. From the legal perspective, there may be a specific answer.
Oh, there is very clearly.
Yeah, that's right. But from the ethical perspective, it's a bit tenuous and challenging, something for you to think about. And I think in an ethics conference, we should get people thinking, does the fetus or should the fetus have rights from the ethical perspective?
So just to clear that up, from a legal perspective, the fetus has no legal rights. You're not considered to be a person or have a legal identity as such until you're born. But having said that, we do have laws like termination of pregnancy, and it does set a mark at 24 weeks because 24 weeks is considered to be the mark of viability, right, or the threshold of viability where you could have a live birth, and there's a chance, the percentage of course will vary depending on various factors, but a chance that if born at that point, the fetus could survive and be a baby and so on. So I suppose in Singapore we've tried to try and balance it in that way. But yeah, the fetus does live inside the mother. That's right. But if you think about it from another angle, in another way, the fetus or the pregnancy is afforded some protection. If you look at the Criminal Procedural Code, you can see that if that there's a miscarriage or there's a loss due to a particular action on a person, then you could be brought under the Criminal Procedural Code for that in that particular sense. So there is some other protection for the fetus or the pregnancy and indirectly the fetus to that regard. Yeah, so it's a criminal offense, for example, to assault somebody who's pregnant and cause the miscarriage. And so that's a criminal offense under the penal code. If we've gone all really quiet, people are like, oh no, are we talking about this? Can we sweep it under the carpet, please? Not talk about it, especially on a Friday evening. No, I think it's good that we are talking about it, right? I mean, I think it is essential to talk about it. And these decisions are often not easy to make, and they can be very, very complicated. And the thing is, at the end of the day, I think people do have a set of values, and those values may differ according to from person to person. But the question is, where can we find common ground, and to what extent do we respect the specific wishes of somebody? So, for example, in this case, if this woman was going to be very mentally distressed by carrying to term a fetus that then would be born, either stillborn or would die very soon afterwards. I think there could be a very strong case to make that this would then pass the threshold required and a termination could be carried out, right? But on the other hand, if this woman thought, actually, I would prefer or feel some sort of closure or whatever it is by continuing to carry on with this pregnancy and deliver what would be a baby by that point nonetheless, then I think that's also something that should be respected. And I think there's space for both of those kind of viewpoints. But maybe some people disagree. Yes?
So I have a question. So the mark of viability is 24 weeks.
Well, I don't know if it's the mark of viability. It's where Singapore has set it in its law, yes.
Yeah,
So that's the legal limit for termination of pregnancy under the Termination of Pregnancy Act. So that's afforded 24 weeks by law.
Yeah, by law. And the numbers is determined because of the viability of the fetus, right? So is it based on this principle? That's the question. And
yeah, I think that's why the 24 weeks is set at 24 weeks and not 20 weeks or 15 weeks or some other number of weeks.
so if it is so, if the fetus have a pathology that will not viable at any point of gestation, for example, beyond 24 weeks,
Yeah.
then why we still need to prove the mother have severely mentally affected, then only can legally do the termination of pregnancy?
Excellent question. Okay. Anybody want to take it?
So there's, I think this kind of question shows, like previous question, demonstrates that sometimes there is a bit of a malalignment between ethics and the law. And you cannot completely answer this sort of question in an imperfect world, in this day and age even. So there's some things which are there which potentially may have to take on a case-by-case basis. And in the way that the law is constructed, it is important to allow for space for that sort of discussion. And I think, the Termination of Pregnancy Act does allow that sort of space, that sort of discussion. And the reason why it was put forth was to protect the mother, and in some way also to protect the fetus as the gestation of the fetus, increases. And so that was the purpose of the law. If you want, you could read that section on in Parliament where it was initially articulated. I think it was in 1969. The reasons why the Termination of Pregnancy Act was established. I think the reasons were given were medical reasons, social reasons, humanitarian reasons, and there was a section on eugenic reasons as well.
Yeah, can't create too many exceptions in the law. I mean, we can create some, but perhaps, and of course it has been on the statute books for some time. But maybe we can move on to that question, just bearing in mind that Reshna wants to jump to. Haha, I can see why. If the termination proceeds, does it make an ethical difference which method is used? And we have two methods here, right? We have the direct potassium injection into the heart of the fetus, or we have inducing the delivery. Maybe here we have even stronger views on what we would like or not like. Does it make a difference? Are we thinking ethically, withdrawing, withholding? Or do people think this is like a form of euthanasia? Okay, if nobody in the audience is going to kind of put their hand up on this one, maybe I can ask the panel. Sorry, throwing you an extra difficult question.
Go first, because first always easier. Legally, I think it doesn't make any difference. Ethically, well, again, then this goes to your values. Okay, so if we have already established that this baby is going to, this fetus is going to be terminated, the pregnancy is going to be terminated. So the end result is going to be the same, right? You're not going to have a live baby. What method you use, does it make a difference? I think you also need to look at the woman's side as well. Which method is safer, for one? I'm not an O&G person, so I'm not exactly sure. Presumably, if you were to induce sort of delivery and all that, you have the I don't know. You might also have a mental problem, right? You might also inflict mental distress on the woman because the woman is actually delivering a baby and then going through the pain and all that, and knowing that she's going to deliver a baby that's not going to live. Whereas if you were to inject the potassium into the heart and the baby dies that way, then in that sense, I think you also have to induce the delivery. The baby has to come out somehow, So I think you still have to induce, but maybe, I'm not sure, maybe it might be easier. So you probably need to ask a bit more on the ONG side, whether it makes any difference to the woman, which method makes a difference. But I think for me, I wouldn't think it's a difference. If you have decided that this pregnancy is going to be terminated, then which method you use is the same. And I think in a sense, I wouldn't consider it as euthanasia either. I would say that eventually actually the child actually died because of the underlying condition, even though yes, you did inject the potassium to stop the heart. But the baby actually was going to die because of lack of kidneys.
There would be absolutely no trouble with, if the birth was induced and it was a live birth, there would be consensus that it's all right not to resuscitate, assuming the baby could potentially live for a few days.
So that has to be explained to the mum and discussed, Yeah. Unless you are in the US Unless you're in the US.
And they might find that very stressful if they had to especially watch that, right? That could...
Yeah, so I just to add on to I completely agree that would be how you do it. Actually, it sits with it's your own moral distress about how it's being done. It's not really the option, and it should be the mother's distress that you look at in order to make that decision, and not your own distress, right? These are the options that are available. And with these two options, these are the possible consequences, alternatives that you have, and which one sits better with the mother. And I think that you have to remember that constant communication. And again, we're looking at this time and space for people to make decisions, right? So already past 24 weeks and 28 weeks. So there is actually time and space for the mom to actually look at these two options if the ethics committee has agreed, yes, it's okay for it today. So that time and space is there. If you flip it, if this was 23 and a half weeks and then it comes into the ethics committee and then you're trying to make that decision, sometimes depending on what the reason for the fetal anomaly is and all that, it can make it quite difficult, because below 24 weeks you can actually make a decision for any reason. A woman can make a decision to abort for any particular reason specifically, right? Any reason specifically. So that tension and that distress, you have to think about it from your own perspective, as well as who is the individual that's actually making that decision. So the information you have on the alternatives and the consequences actually makes more of a difference on the other side, not so much to you, and you should be able to make that balancing sort of choice in that sense. Does that make sense?
Yeah, so in this kind of situation, I think it really highlights the importance for individual clinicians to think ethically. It's not about a committee making a decision, or remote from the situation, but the clinicians on the ground need to understand the ethics, how to resolve their own moral dilemmas and apply, good principles to this clinical situation. And it's not just about pushing blame or pushing responsibility, but it's really about caring for the patient. So that's the first principle to take. The second principle to remember is that there are many different clinicians and groups of specialists on the ground. So it would be the obstetricians, and they can decide, or they can weigh in, value add on what's safest for the mother. Two is that you can look at neonatal sort of like teams, and they can look at what possibilities are there for the care of the child to make the child comfortable after the child is born. And of course, the palliative team is very good at bridging the various subspecialties, particularly in this case where outcomes are so poor. And of course, the nursing staff have to be on board as well, and they have to be comfortable with the care of the child as well. So there are so many people on the ground, to bring together to care for this patient or the child. And I think it's important for every, one of the members of the team to have good ethical grounding.
And that makes total sense. Any more comments, especially about whether or not we can inject potassium? Do want to mention something though while you're thinking about whether to raise your hands. This lady was given the option to terminate earlier before 24 weeks when already there was some anomalies discovered. Right? The fact that she carried on with it means that this was probably very much a wanted baby. And she was prepared to care for a baby with probably what was going to be a disability or other health problem. This can't have been an easy decision for her. It's not something people take lightly, right? So, okay, about the method. Maybe we should ask, well, Reshna, since you've raised it already, what do you think about the two methods? Do you think we can inject potassium into the heart? No, not personally, legally. Legally, first legally, then personally. Legally, can we inject potassium into the heart?
Well, there are two ways, clinically sound ways, to terminate a pregnancy if needed, if it's going to harm the mother, okay? One is by potassium and getting it stillbirth, and the other one is inducing delivery or carrying it full term in a natural birth and then die. Okay, so these are the three things you've got to think. As Kumu nicely put it, it has to rest with an individual mother, what she feels strongly, how she wants to terminate, knowing that this baby is not going to be alive. Okay, so that's a legal perspective of that. That's where the clinician has to counsel the mother fully to understand, to make that informed decision. Okay, personally, I don't think I'm a pro-life person, and to me, injecting something would be not a violent act, and I wouldn't want to do a sort of a violent act on a baby because I don't know how it's going to affect that. If it's going to be naturally done, I would prefer that. That's my personal view.
Actually, on that point, I would like to sort of draw attention to what Kumu was saying, and I think that's true. When we serve on the clinical ethics committee, what are we making the decision for? It's actually for the patient, right? But yes, we have our own values and we have our own beliefs, and whether some of us are pro-life, pro-choice, or whatever. But then, if you think about it, should we be making the decision based on our values or based on our patient's values, whatever values that you know of the patient? Is it right? Is it ethical for us to use our values to say that I'm not comfortable with injecting potassium, so I'm going to say I will only approve if you deliver naturally, even though the woman says I prefer that I don't want to see a live baby. So I guess it's difficult, right? Because we have very strong views. Certain views are very strongly held. Is it a violation of your own kind of ethics if you were to approve something that you wouldn't approve for yourself, but your patient wants it?
I think that those are very difficult questions that we face on ethics committee, being able to manage our own biases, even though we might have very strong views about some things, and maybe we can even advocate for them, but should we advocate for them to the extent that we insist that other people also do them? But then there must be a limit, right, Suresh, who's putting his hand up?
Can we, as a practitioner at the other end, can we also have this latitude for being a conscientious objector?
Yeah, of course.
Yeah. So that may be the balance.
So one of the things that as physicians that we also have to remember is that sometimes we can say no if we don't want to. We are allowed to, as long as there's somebody else out there that maybe can, give that option as well, right? Because these are the things we have to be able to sit right with ourselves as well. We are, after all, human beings. And we feel and we think, so do they. So we also have to be able to say no. I think a plastic surgeon said that to me once. The best thing I ever learned in a consult was to just say no to my patient. And I agree, sometimes that's okay.
Would this be the 14-year-old who wants a breast enhancement or something? Yeah. I don't want you to tell my parents. I have my own money. Oh, okay. Yes, Nita.
I just want to know very respectfully, and because thank you for being brave and saying I'm pro-life in this room. Thank you, I respect that. But I just wanted to know, I appreciate that injecting KCL is something that would cause a lot of distress, but I want to know how that's different from having a live birth and allowing the baby to die. Anyone who wants to answer that? Ethically, to me, it's very similar. Mostly distress to the parent or the doctors. Mostly distress to the parent and the doctors would be the big difference to me. But
and I don't think you guys have to answer it, but you have to think about it. Because, it's one of those things. It is one of those things. That's why I say you have to you have to think about yourself in that, what I would do. But you also have to think about when you ask that question, the question that is asked of the ethics committee is it okay for this post-20? My answer would be yes, and I give my reasons for it, and I go through the way I go through and stuff like that. How it's done is actually not the ethics committee's choice, or not to tell her what to do specifically, because I agree, for me that choice lies with the woman and how she wants it done, right? And again, giving her that ethical space and latitude, like we do for parents, even if we disagree with a decision, are they allowed that latitude? Are they allowed that ethical space? Are they given the options available that sits comfortably and ethically with them? And that is something you have to, these kind of, yes, no, I'm pro. It's great that you're brave enough to say it or not say it, but you think about it. Just think about it from that perspective, because our job is to help and to comfort, right? And all of these things. And, injecting KCL, it sounds violent to somebody, but, when you actually know what it is, it may not be as violent as it is. And it is a personal perception of that, right? It's a personal view, right? So, you have to think. And like I say, there are certain things you can say no if you're not comfortable with it.
Welcome. Okay. Oh, wow, on that somber note. Okay, so I think the consensus kind of is that on this, that if it's... Sorry? Oh, so it looks like, we're aware that this law exists, that if there is this risk to the lady who's carrying the pregnant woman, whether it's a physical risk or a mental risk, then there could be reasons to terminate after 24 weeks, right? So that would be the exception under the law, and how that's interpreted is a clinical judgment and something that will be explored between the clinicians and the patient. But we haven't really quite, I don't know whether we've reached consensus on KCL versus inducing to birth, because I think some people might have very strong views about whether one way or the other would be preferable, depending on how you're looking at this. But I think most of us would probably agree, that usually it would be something that it would be discussed in quite a bit of detail with the pregnant woman to find out what her perspective or preference would be in the circumstances and how that might affect her own well-being. But of course, the overriding concern is if one of those methods was unsafe or less safe for her, right, cause some potential of physical harm, then the other option would definitely be the one to be preferred. Okay, does that sound about right? Okay, so maybe we can move from a case that involves so we've gone from one end of the spectrum. So now from pregnancy, we're now going to move to tubal ligation. And then after this, sex. Well, we're kind of also talking about sex in the context of tubal ligation.
Sorry.
Oh, sorry.
Yeah, sorry. I've got a question.
Sure.
So just to check, so if it's the birth was a pair of twins, that means like one child is sick while the other is healthy, then how does it proceed? Like, do they still continue with the abortion? to induce? Or?
So that comes with that whole fetal reduction sort of an issue specifically.
Fetal reduction.
So it's a different, sort of aspect, I think, of,
Yes.
of
And then
that.
also if it's like before 24 weeks, let's say if they found out and then they can do it without any reason, will the doctors still go ahead to proceed? But you
That would
might
be the
jeopardize.
So that would be the doctor's decision, right? Because by law, before 24 weeks, you want to abort 1 or 2, or if you are carrying triplets and you want to abort triplets, you can. Do you know what I mean? But that would be a personal decision, right?
No, but not to abort all, like just maybe 1. Like maybe you don't need 2 kids, you only need 1. And then if they even happen to choose by gender. So I mean for various reasons. Like
You mean for any reason? So you're not talking about if the fetus has got any kind of bilateral kidney problem or whatever it is. You're talking about two...
One thing is maybe about health. Like
you're talking
one
about
is
two
sick.
healthy fetuses. Is that what
Yes,
you're saying? And you're asking whether it's possible to carry out a fetal reduction, so to go from a twin pregnancy to a singleton pregnancy before 24 weeks.
Yes.
The answer is definitely yes.
It's not illegal, but I would not know an obstetrician that would do that.
Yeah. So legally you can.
In a sense. Legally, there's nothing
and then
that
whether
stops
like if they do it and then like it causes from 2 birth became 1 and then became 0, and whether the doctors get sued in the end,
So the thing about it is there is that potential, right? There's no such thing as... So in terms of 24 weeks, you want to abort 1, 2, legally, you guys can correct me if I'm wrong, there's no law that says you can't. But I do know from the obstetricians themselves, they're much happier doing triplet to double, but would not do triplet to single, because the survival rates of twins and the carrying healthy twins to term and having normal babies and all that maternal health part of things for twins is much better now than it was before. So I don't know any obstetrician that will do it personally, right? Can they do it? Yes, they can, from a legal perspective. But that would be a decision between the obstetrician, their own moral values specifically, and what it is there. If you understand what I mean? That there is no legal stoppage for you. But it is then your own conscientious objector, yes or no, whether you would do it or not from an obstetrician's point of view. But the sentiment is carrying twins to term, healthy, and if there's no other health problems with the other twin, and the reason to abort would be for just social reasons, I personally don't know any clinician that is likely to do it. But that's my point of view.
I think the guidelines for this, So ACOG has got guidelines for selective fetal reduction. ACOG, American College of Obstetrics and Gynecology. So I don't know any OBGYNs in the room, but in any case, I think you can look up the reference. There are some guidelines for selective fetal reduction. But just to say also that selective fetal reduction is also not benign for the surviving twin. There's a risk of neurological injury, and typically what they do is they will need to do a fetal MRI as well, just to make sure that the neurological status is okay for the surviving twin.
So it's more, would I say it's more ethical? Like if the lady was expecting a twin birth that carry to full term so that one comes out alive and then the other is a stillbirth. I mean,
I thought you mean that the twins are both healthy.
No, I mean, there's a few scenarios. So one scenario, let's say one is healthy, one is not, but it's a twin birth and then it's like 28 weeks. And then the other one is if they're healthy and then below 24 weeks and they want to choose to remove. Yeah, just some thoughts about it.
I guess if you have twins and one twin is not likely to survive, whether you abort or whether you selectively reduce the twin pregnancy into a singleton would depend on the safety of that singleton. Because if the woman still wants that singleton, then selectively aborting the unhealthy twin might actually cause abortion of both. And then you're ending up with no children. Yeah. So if the twin is if the unhealthy twin is going to die anyway, you might actually, the unhealthy twin might actually get resorbed, and then you get a healthy singleton being born. But if the unhealthy twin were to cause a problem to the singleton, if the unhealthy twin were to, say, maybe have blood transferred over to him or whatever, I can't remember my ONG lah, then if you want to do a procedure to sort of save the singleton, then again you have to, it's a medical decision, right? It's a medical decision between the woman and the thing. I'm not sure that the ethics would come into it. Because this is now a medical decision, provided the mother is willing. Okay? So if you have the scenario where the twins are healthy, okay, and it is before the 24 weeks gestation, then the selective reduction, again, is a mother and a ONG kind of thing. But again, they have to be aware that if you reduce one, you might actually reduce both. You might actually abort both. That the risk is there. So if the mother is apprised of all the risk, and she still wants to carry on, then, it is between, and there is a willing ONG doctor to do it, then it doesn't contravene the law before 24 weeks. After 24 weeks, I think the same rules apply.
Yes.
Okay. So, but then you also have the ethics of which healthy twin to choose, right, to reduce. Yes. So that, again, is a medical decision. The ONG have their kind of criteria and all that. But then, of course, if you want to talk about an existential thing and when does life begin and all that, that's a whole different thing altogether. But if you want to talk practically, it's going to be between the woman and the ONG. So then, of course, then there's another thing, usually all these multiple pregnancies, sometimes they are because of IVF, right? Then people say, how ethical is it to put in more than one embryo? Okay, usually all these multiple pregnancies because you put in more than one embryo. But luckily, nowadays, the IVF technology is so much better that they don't normally put in more than two now. In fact, actually, I think the rule now is one. The rule now is one. Last time they put 3, 4, and you get all these triplets, quadruplets that they have to reduce and stuff, causing so much, moral distress and all. And then people will say, no, you use public funds to go and fund IVF, and here you are aborting these babies that I funded, So that's also another whole new issue, But luckily now it's less of it already.
Okay, thank you.
Great. Okay. Should we move on to the next case? Time check, right? So this is Mr. and Mrs. Fung, who are requesting a tubal ligation for their 15-year-old daughter, Min, who has global developmental delay. They're concerned that she may be taken advantage of and risks being impregnated by opportunists. Mr. and Mrs. Fung worry that if she becomes pregnant, they will end up having to look after the child, and they would struggle to do so because they're getting older. They want a permanent solution instead of other temporary contraceptives such as oral contraception or IUD, and believe this would be easier for their daughter and would set their mind at peace. So guess what? We're going to ask you another PolyV question. So the question is, which of the following conditions should be satisfied for the doctor to carry out the tubal ligation on Min? A, the parents give consent and 2 independent doctors agree. B, at least one parent applies to the court for an order declaring it's in Min's best interests to have the tubal ligation. C, Min gives consent. She was assessed by a psychiatrist to have capacity to consent. D, the parents and Min give consent. Min was assessed by a psychiatrist to have capacity to consent. Oh, okay, how fascinating. All right. It kind of was a little bit of a trick question, but actually, and it's interesting, it goes in sort of increasing order, right? So the lowest response was parents give consent and 2 independent doctors agree. So I'm glad to say that most of you did not choose that option because that was definitely not the right one. At least one parent applies to the court for an order declaring it's Min's best interest to have the tubal ligation. That was actually the strongest answer, and that's actually in our law. It's in the Voluntary Sterilization Act. Min gives consent. She was assessed by a psychiatrist to give capacity to consent. So most of you, I think, went along this line because you think the Mental Capacity Act and all the rest of it allows you, if you have, or maybe you thought she was Gillick competent, but I think that's a bit dicey, right, when you've got global development delay and you're talking about a 15-year-old wanting a very significant procedure. So perhaps, but I can see why you went for that. And the last option, parents and Min give consent, and Min was assessed to have capacity. Again, I think a slight problem here, in part perhaps to protect Min's interests in her involvement in the process of making a decision. So, very interesting that you about the spread of options. But basically, so if nothing else, please know the Voluntary Sterilization Act requires you to get a court order for something like this. So please go and get a court order. Any comments from the panelists?
I mean, from my perspective is that tubal ligation is a procedure. It's a surgical procedure, and it has its benefits and it has its risks as well. And it is, if it's done well, it's probably permanent, 100% and stuff like that. But there are other ways to make that, I suppose, chemical sterilization, which is maybe an option. I think that maybe the parents may want to explore a little bit first before we go into surgery. Sometimes because they don't know that or are not aware that these are the options that are available. So I probably would have that conversation. Again, information, options, the consequences of this option, other options available, what are the consequences of the other options, and what is best for that individual. I agree with Sumi, though, that when you have global developmental delay, that capacity, I think one person can say there is capacity, then you can be assessed on another day, may not have the capacity, and it is a real thing when parents think about these things and go, then I'll have to look after a kid at the age of a certain age and stuff like that. These are things that we have come across at that later stage in life. And if this individual was 28 and still had global developmental delay and still was, and then how would you treat that? I mean, you got to look at it from that perspective, right? Again, this is a minor. We have an act that helps with this voluntary sterilization and that court order. So we have guidance. Again, here the law guides you quite a bit on what needs to be done or what can be done and what options the parents have. But I would always, as a clinician, I suppose dealing with teens, I will always think of the safest option possible first, safest best option, I think, and that should be presented to the parents specifically.
Yeah, preferably without any kind of surgical intervention being required, which then obviously carries its own risks.
So the chemical sterilization, how effective is it?
Contraception, if you do contraception at like depot or whatever it is, it can be quite good and quite high in a sense, and it's things like LARCs, where long-acting reversible contraception can last for years.
So I wonder, because when we deal with cases like this, we are actually, in a sense, the best interest of the patient, in a sense, is kind of second to the parents' wishes. It's the parents' fear of her getting pregnant, the parents' difficulty in managing the child, and all that. I wonder how ethical it is to subject a globally developmental person who won't understand, if he's assessed not to understand, a procedure that though it is low risk, still it's not no risk. Okay, low crime is no crime. So low risk doesn't mean no risk. Okay, so can you imagine what the consequences if she goes for a procedure and then she dies on the table? What are the parents going to feel? So.
Yeah, no, actually thinking through this, there's so much more, right? So the first consideration is this. I mean, while she has got developmental delay, and to what degree is she delayed? And I think you can't assume mental capacity or that she doesn't have mental capacity, but we need to look at the specific procedure and the medical situation and see whether she understands the procedure, she understands the risks, the consequences, the other options and alternatives, and whether she can remember that and hold that or not. So that's from the perspective of mental capacity. Then again, if let's say she's found to have mental capacity, then that whole situation now flips around. And the question then is she that delayed to not be able to defend, to protect herself, from the social perspective? And then we come to that best interest question, from Yoke. Is this to her best interest to actually have the tubal ligation or any other form of contraception at this point in time? And as we consider that, then we have to weigh the risk benefits and also whether other options are available with respect to contraception in this situation. And if these other options would be possible and would be, acceptable to the parents as well as to Min. So there are quite a few things to tease out in this situation, and more information is probably good in this situation.
Can I just be clear? I think that MCA doesn't apply to this child, right? She's 15 years
below
old.
age.
So it's not MCA. So actually it should be...
Yes, just
Gilead.
capacity.
I suppose she's 15. So actually Gilead, actually. So if Singapore had affirmed Gilead competence, whether or not she's developmentally delayed, you should actually assess whether she's Gilead competent or not.
Yes.
And if she's found not to be Gilead competent, then it's the same as if it's a child who has no decisional capacity. Okay, not that she's not that it's under MCA. So MCA doesn't apply for minors, lah.
And to just be clear, even if we're going down the route of minors, right? The Voluntary Sterilization Act has taken away the power from parents to make a decision for your 15-year-old in this situation. Right? They've made very clear that actually a court order is required because it's such a permanent procedure.
So who will apply for such an...
Usually it's one of the parents.
They apply for it, but they have no say.
Yes, that's right. Well, the fact that they're applying for it means that they want it. Right? Otherwise, they won't be making an application. So they're applying for permission to go ahead with this procedure.
And if the other parent opposes?
Well, that would be interesting. I hope quite interesting if the court did decide on that basis that had a differing points of views from the parents. Yes, Wan Lin.
Yes, I have few thoughts. How is because she's determining whether she's Gilead competent is one, and then how the extent of a global developmental delay, and if we wait for a few years, will she then acquire mental capacity? And the other thing is, if even if she does agree with her parents at this point, will she change her mind in a few years' time when she's an adult? And is she also, depending on the extent of global developmental delay, would she be wanting to get married in the future? And so many thoughts on this.
All very good questions and reasons probably why the court won't grant the order. For exactly those reasons, because there's an alternative. This person may, unless the condition is such that they're not going to, very high chance they're not going to develop any capacity moving forward. But also, there are actually a lot of people with various conditions who do land up getting married or having a relationship with somebody, and some of them even do carry on to have children.
So I have a patient with Down syndrome who married another Down syndrome, not child, adult already, because they met in the Down Syndrome Association.
Yeah.
So, who are we to say that they are not capable of love and relationship? They're probably even, their relationship might be stronger than a lot of normal people.
So maybe just to talk a bit again about developing mental capacity. So I think it's important to think about the words over here, but what do we mean by mental capacity? And I think there's a legal perspective and there's also a developmental perspective, and I think it's important to break it down to the developmental perspective, particularly in our situation, because of the degree of applicability of Gilead in this situation. I put it that way because we know Gilead competency is well known in the United Kingdom and in other sort of English law jurisdictions. The consideration that perhaps I want to be a bit provocative is how far does Gilead competence apply to Singapore? And I would argue that the basis for that decision-making process, or the basis for, allowing a person to make a decision, either Gilead competency or not, or consideration of mental capacity, would be as was enunciated by the district judge who looked at the case of that COVID vaccine vaccination situation. So there was a case where I think a 16-year-old girl, was wanted to have COVID vaccine, and this child was in joint custody. Yeah, we did that just now, right? So I mean, I guess to cut to the chase, the words that Kenneth Yap, the district judge, used was a reasoned and informed decision. Or is it informed and reasoned decision? But those two words were used, and I think they reflect the basic needs that have to be fulfilled for a person to give adequate consent for a procedure at an age that is of below 16 of a minor. So just to put it as a little bit of something thought-provoking.
Yeah, when are children not children anymore? Yes, or can make decisions on their own. No, we do have to push on to this, but I'll be interested to hear just one last question.
I just ask for the court order, who will the court consult before?
Oh, very legalistic question. Yeah, actually, I would imagine that, no, I wouldn't. I don't know. The answer to that is I don't know. But the logical outcome, or if you think about it logically, it would be they would be talking about the parents and they would be talking to the medical professionals. But I'm not familiar with the case myself in Singapore which has dealt with this. Certainly not recently. These cases don't often get published and reasons published, but my common sense and Reshna might be more familiar with the case. My common sense is telling me that they would be speaking to the parents, they would be speaking to the girl herself, and they would be speaking to the relevant medical professionals. Reshna, do you want to add anything?
Yeah, I think, I don't know about that case, the sterilization case, but I would have thought, yes, all parties will be consulted by the court to make that decision. But the two comments, not being a medically trained person, I don't know if tubal ligation is irreversible or...
I don't think it is, right? Or is it becoming more advanced now? We can reverse.
Technically, you can reattach the tubes again, but the likelihood of pregnancy is going to be very low.
Okay,
so likely practically irreversible.
I think you were very right to say we need more information to tease out some of the issues. From a legal perspective, now, okay, the parents are making that decision because under the Children's Act, under 18 or under 21, they can make decisions unless the GILIC competency applies, that rules strongly. So they can make that decision now, and because they want a permanent solution. But what we don't understand from the case study, what is a global underdevelopment? I don't understand that, and what is mental capacity?
So that usually is in the domains of maybe language. I suppose when you look at global developmental delay, you look at certain IQ levels and things like that. So I kind of agree there, but may likely need a reassessment on whether that is still an issue or not an issue in the sense when she reaches a certain age.
So her IQ may be low, if you say so, but doesn't mean...
speech, language, the domains of maybe motor control and walking, when it says global, that in all these domains there are some deficits. And it is very unlikely that these deficits will become 100% normal in that sense.
So those are very important considerations when you actually make an assessment. In Singapore now, although that was a vaccination case, but it did take GILIC principles to a certain extent, and the court did give us guidance, although there's no GILIC competency test case actually endorsed in Singapore. So this is the only guidance we have, although it's not at an apex court. The judge clearly said, A, does she have the intelligence to make that decision? Does she have the maturity to make that decision? Is she influenced by anybody? So all those criteria will help in this case if she's, although underdeveloped, but mental capacity, she still has mental capacity, but all these assessments will need to be taken into consideration. Otherwise, it falls again, as you rightly pointed out, under the Children's Act, the the parents have a decision to make. Now, I'm glad we have the law here on our side for sterilization. Tubal ligation is to be taken seriously, because what if she gets older and somebody relevantly asked that she may want to make her decisions later? Otherwise, she'll have a loss of chance of having babies and all that. So, yeah, I'm glad the court is there to protect, when such important decisions are made by parents. Yeah. Okay.
Thank you, Prashna. Sorry, looking at time. Okay, if it's all right, we're going to move on to variation A, right? Now, promised sex, but only 10 minutes before we're supposed to end. So, a 15-and-a-half-year-old girl wants contraceptives for sex with her teenager boyfriend and doesn't want parents to know. Who wants to take this one? Or maybe yes, or maybe somebody in the audience. How many of you have prescribed contraceptives to teenagers? You have, Jocelyn, there you go. Oh, you will, but you haven't. Okay. So you prescribe contraceptives to this 15-and-a-half-year-old? Okay.
And she understands her, because nowadays, I think theoretically, as I mentioned, practically I haven't had that specific case. I wouldn't prescribe it or think about prescribing for every 15.5 years. I want to establish an understanding of what she's asking for as well.
Okay.
And has she... the first thing also, this one is probably offense. There's probably a crime going on there as well. Less than 16 years old, there's a problem there.
Yeah, we'll talk about that in a second. Okay, thank you. Anyone else? Yes. Are you standing up? Because, oh no, you're sitting down. Anyone else with views on this? Okay, what about the panel?
So 15 and a half, so below 16 in Singapore, minors that have sex, it's against the law. So if you prescribe, and this is by the, and I'm just talking about, not from a clinical perspective, but you prescribe contraception and you're actually kind of aiding and abetting that. This is what I've been told by someone from AGC, very specifically, all right? So I'm not saying that don't prescribe, but I have had physicians tell me, I mean, this is kind of what you guys think about it. People have asked me, do I prescribe? And I work in a hospital that says Women's and Children's Hospital. So I do have colleagues that can prescribe and prescribe it way better than I do. So I will tell you I don't prescribe. Not from a sense because I don't want to get into trouble, but because I don't have to, in a sense. But I have had family physician colleagues tell me this before. And giving you a case of a 15-and-a-half-year-old international student comes in with her mom, and the mom knows that she's going to have sex with her boyfriend and asks for contraception so that the mom is giving consent. So what do? I just give it a spin and a twist in that sense. So because I don't want to tell my physicians that you aid and abet a felony, which is in the penal code at this current point in time, so it is actually, if you know of someone going out to have sex with someone who is less than 16, then yes. So what they've done is that in Singapore law, I will have to report you to the police. Now, reporting you to the police doesn't mean you get charged in court. So I will report you to the police, and after I do that, and this is Singapore's law, and this is the context and all that, after that I will prescribe for you. That is how practicably I have heard of individuals go around in that sense and do both their fiduciary duty as well as not get into trouble with the law or not aiding and abetting in a sense. My issue is 22-year-old boyfriend. Okay, so in our laws we don't have that age.
Sorry, I didn't mean to go to case variation B, but we may as well.
But when you come from a child and young person advocacy point of view, this age difference makes a difference and in certain countries, if you're more than a couple of years older, even if with being in the age of consent, it makes a difference. It is considered grooming. It is considered
in Singapore statutory rape.
Yeah, below 14, it's statutory rape in Singapore.
That means consent is irrelevant.
Right? So you kind of need to know your laws in that way. So just to remind everyone, in 2007 or 2008, that whole thing about illegal below the age of 16 was moved from the Women's Charter to the Penal Code. And in the Women's Charter, it was unlawful carnal connection, I think it was called a long, long time ago. And they moved it to the Penal Code basically to protect both males and females from the Women's Charter. But then it became such that you would have to report for those under 16, even if it's consensual between two 15-year-olds or two 16-year-olds. That made it such. What the police do with that, then that is left up to the investigative part of things.
So just to be clear on the law part, the age to have sex in Singapore is 16, right? If it's commercial sex, it's 18. If you're under 14 and having sex, that's statutory rape. Right, so that's, if you like, the most serious offense. Under 14, it's statutory rape. There's absolutely no excuse for that, basically.
16, so under 16 is illegal. It's in the Penal Code.
Even under 16?
But even if it's consensual, let's say if it's two 15-year-olds. So, so it is just... It's
no, it's not
below
statutory
14
rape.
is statutory rape.
No, calling that depends, is the punishment. It is the punishment why you want to call it statutory rape and why you say it's illegal. The punishment for statutory rape is probably more.
Statutory rape is higher because it's assumed that somebody who's younger has even less ability to consent, has probably been groomed and manipulated in some way to undergo, to have sex. That's why the age is set at a younger age compared to, say, sex between 15 and, within two 15-year-olds, or sex between, 15 or 14-year-olds, right? Which probably some people will believe that that's less morally objectionable than, say, a 13-year-old and a 22-year-old. Well, that's clearly illegal anyway. But even if it was, say, a 15-year-old and a 30-year-old, we probably have more concerns about it because, again, you'd be thinking about grooming, manipulation, those sorts of concerns, as opposed to, say, two 15-year-olds who are just being stupid, and have raging hormones and want to discover their bodies and this sort of type thing, which seems... in some ways less harmful.
So from what I understand, the AGC would make the decision as to prosecute or not. And usually they look for situations in which there's a power imbalance, there's a vulnerable individual, and they want to prevent that from actually happening.
Yes.
So actually, I think there are two parts to it. There is no problem with a physician prescribing oral contraceptives. There's no law that prevents you from prescribing oral contraceptives. I do it all the time, but not for kids to have sex, to control their menstrual cycle and, to reduce menorrhagia and things like that. So there is no law that prohibits a doctor from prescribing oral contraceptives. So then, does the intent matter? And that comes to whether there's a crime that's happened now. If she hasn't had sex yet, I don't know whether you can report. Because the crime hasn't happened, right? She says she wants to have sex. Then, you tell the police she wants to have sex, and then she goes and she says, I didn't want. Then what you gonna say? If you know they have already had sex, then maybe it's a stronger case. I don't know. And again,
unless you have a reasonable excuse. Your get-out card is reasonable excuse. Reasonable excuse has not been defined under the law yet. So yes, it's mandatory reporting for most offences in Chapter 16 of the Penal Code, which is offences against the person. So those are automatically arrestable offences. And all these things that we've just talked about, statutory rape, sex with consenting 15-year-olds, these are reportable offences. But I would say that you won't have a reasonable excuse to report that, the 13-year-old and the 22-year-old. I can't imagine any reasonable excuse you would have to not report that. You could make an argument not to report two 15-and-a-half-year-olds who are, just being a little bit silly and engaging in sex. But, having said all that, I don't know. On the first day when we were here, I put up some of those news reports, and one of them was a very sad news report that happened recently in Singapore where two teenagers had sex, and, the girl landed up, I think she was 15, landed up being pregnant, and she was so fearful to tell anybody about it right? And apparently the boy tried to buy, he couldn't buy contraception, couldn't buy condoms because he had such a young-looking face. And of course, he is young, so he couldn't go to 7-Eleven or wherever it is. He felt he couldn't go and buy contraception. So the result was this girl had the baby in her parents' home and was stillborn and buried the baby in the garden. And, it's terribly sad to think that, our sex education, there's been some sort of failure of sex education here, and that this poor young girl and her boyfriend had to undergo this extremely stressful and must be traumatic, set of events. So
just out of information-wise, Singapore has one of the most liberal abortion laws on the planet. Okay.
But it's better if you don't want to have them to just have contraception.
But you don't also want to have to use abortion as a form of contraception, and that is what I have an issue with, in a sense. So you need to have both. Your sexual health education has to be at a level that is there. No information or not giving information is really terrible, because teenagers find information in the most useless places, which is their best friend next door or something like that, right? And who never have the appropriate information, or on social media, which oftentimes when you Google something, the worst parts of it come out as the top searches and not the best information that comes out at the top. So in a sense, information is always power, right? So I have an issue with the fact that abortion can be used in a way that it's not supposed to be used as. Right? So, you got to, again, balancing principles and having the information and what the information is actually really, really important in a sense.
Okay, mindful of time. I don't know if anybody has any last comments or queries or questions, and the countdown is there for me to make sure we don't overrun.
Sorry, just to play the devil's advocate, because there is this notion of harm minimization versus harm elimination. Here we go with harm elimination because we mentioned that liberalization of abortion. So how about liberalization of oral contraceptive pills if, let's say, hormones are always raging? So
we are really, really good at harm elimination. Let's say if you ask our teens maybe 10 years ago, what did you learn in sex ed? Okay, if I have sex, I have HIV. We're very good. So they all know that, right? Harm minimization is not something that we are actually really good at from a public health messaging point of view. I think we're getting better at it, in a sense. But again, these are biopsychosocial constructs, right? When you're looking at things like this. I've got parents who HPV vaccine. You give my 12-year-old HPV. Are you telling them it's okay to have sex now? That's what. We have to face the reality of the questions that are being asked, right? So semantics and wording is actually quite important. So I call HPV vaccine cancer preventing vaccine, not sex education vaccine.